First of all, I want to say thank you again for those people participating remotely, looking into the camera. We love you. We miss you. We thank you. I heard that those who had fellowship during lunch with Mark had a ball. Our Novant crew, we miss you. Great. Our next session is the kiss of death. And as we were walking here, Jared had mentioned, gosh, what an appropriate title if you have to go right after lunch, right? But this is the lovely and the talented Jaymie Wilson. Let me let you know about Jaymie. She comes with an ICU palliative care background. She transitioned to hospice after receiving her nurse practitioner degree in 2015. She began at PDC as a clinical account manager in 2017 and now serves as PDC's Vice President of Operations. And that's a pretty new title, isn't it?
End of last year.
End of last year. Congratulations. Well deserved. When not working, Jaymie likes bad jokes. That's not actually on here. Jaymie likes to spend time with family, especially doing outside activities like camping, hiking, and laking, which is not technically a word, but I think we all understand it. Okay, I'm going to hand you the microphone, and we look forward to this, and thank you.
Thank you. Hi. So the session after me is going to be a lot to compete with, Jen. So I brought candy and anything else you guys want. So mints, okay, the reason behind the mints is, did you guys ever have to take, when you took the ACT or like boards or anything, there were always mints that and it was disgusting and I never liked them. But it's because the sugar obviously will wake you up and then the peppermint actually like sparks your brain. So please stay awake while I talk. So the originally this session was going to be about reporting, and are the hospices using all the reports? Do they understand the reports that all of the vendors are offering? And then it just kind of snowballed because then I realized that, so at PDC, we post like 14 reports every month, and then we also have weekly reports. I know no one has time to sit down and look through 14 reports, like I get it. So it just kind of morphed more into what reports are good for you, and are you guys using everything that your vendors are offering, and are you using your vendors appropriately, and are your vendors a partner with you in your growth, not just there to provide that service, but actually partnering with you and helping and assisting with your growth, and like Jared said, taking headaches away from you. So that's where it all kind of morphs. So it's not just about the reporting. All right. So I like the face you make when the lady behind you in church takes forever opening the peppermint, except it's usually cough drops and you always hear the crackling. Yeah. So we're going to talk about the dangling carrot, and that's mainly if you have another vendor coming to try and sell. Yeah. Thanks, Choctaw. The dangling carrot. So other vendors coming to sell to you, what is the dangling carrot that they're showing in your face? Because later I'm pulling in Billy and Jared too from the other vendors, because we're not selling anything, but you have to be very cautious and stay on top of the traps that they're going to use as dangling carrots for you. And then know your efficiencies, know what you do really well at, and have an early recognition of your inefficiencies, and always be on the lookout for the traps. Getting mixed signals. That's basically what I feel like when I'm doing anything.
Is that the first time you've seen this?
No, but I still giggle because it's funny. So basically, as we go through all of this, background being so clinical, I tend to look at everything more from a clinical rather than like an administrative level. So I kind of have squirrel moments, but I apologize in advance, but I feel like they were all really important points to talk about. But a lot of the things that the dangling carrots, it's all either money driven or efficiency driven. Whereas if you're really looking at someone to really partner with and to really help you grow, nothing should surprise you when they give you reports. Nothing should really be surprising when they show you trends or anything like that. you should kind of have an idea. You should have your pulse on where your trends are, where your money is going, and things like that. So when you actually read the reports or you see PPD, you shouldn't be shocked by it. The numbers will not lie. The data doesn't lie. People can lie. That's Jordan's line. That was a good one. So you always need the data to help you back up any decision. So a lot of the dangling carrots that vendors will talk about are how they can save you money, how they can save you time, and any extras that they might talk about. So before you can even fall into looking at other vendors, because you should, but you need to know what you like, what you're doing really well, and what you're not doing very well at, and where you can improve, and see if that aligns with everything else. So the basis for everything should be patient care. Obviously, you guys are talking in the front row. If you could just... I'm easily distracted. So the basis for everything is patient. So if you guys are doing really, really well at your patient care, everything else is going to fall into place. If your patients are happy and doing well, you're doing a really good job at goals of care, then everything else is going to come easier. I came from a background of like a perfect hospice where we used every person on the team really, really well. And we had our pharmacist, our medical directors, nurse practitioners, social workers, chaplain. We all sat around the table like how it's supposed to be. We actually did it every week. And it was so helpful. And then when I got into this role, I realized that that isn't happening everywhere. And it's really sad because if you don't have a really solid goals of care, you can spend a lot of money on things that you don't need. So the biggest thing that I see a lot of is, I'm getting ahead of myself already. We spend a lot of money on medication. So I'm from the PBM side, the pharmacy side. We spend a lot of money on medications trying to help the patient with whatever symptom it is they're working on at that time or you're trying to fix. When you could go to your social worker and say, will you get down to the bottom of this? We've tried every anxiolytic there is out there. It's not working. Talk to your chaplain. So many pastors I've had that were all of a sudden scared to die. So we spent a lot of money on medications to try and help them with the nausea, help them with the anxiety, help them with the pain, when really you send a chaplain or social worker in there for an hour, they get down to the bottom of it. And it's immensely helpful to use everyone on your team the way that they should be used. The only way you'll meet your goals is if you have that solid goals of care and you're using everyone on your team to meet those. Then if your patients are happy, it's going to lead to referrals, which then as you grow, you as an organization are growing, your staff is happier because they know that they're accomplishing really good goals and they're actually helping people. You do need to make sure that everyone's on the same page. So that's something I see a lot of is inconsistencies with the nurses on what they advocate to order, inconsistencies if you have more than one medical director or provider, they have different prescribing habits, different ways to treat things. Some are more expensive than the others. It's really important to get everyone on the same page and make sure that education is happening to everyone. Everyone understands the mission. I see a lot of that, especially on the provider side, so the physicians and the NPs. They're not looking at the bills at the end of the month, so they're just ordering a bunch of things, and that can be a big problem when then the administrators get the bill and they have to look through the bill. There's inconsistency there, and that can lead to a lot of money that you didn't need to spend that way. Utilize the full team, like I already talked about, and then quality versus quantity. So however many nurses or staff members you have, are they good? Do they understand the mission? And are you all on the same page? Then on the organizational level, if you've done really good patient care, your staff is happy, then you need to look at your necessary and unnecessary costs. Is there anything that you're paying for on a reoccurring basis that you don't need to? Those are often overlooked. Review your reports and your benchmarks, and always stay on top of your compliance, which is a headache to keep on top of all the compliance for hospice. Okay, so I said this morning that I was going to talk about Dame Cicely Saunders. So the reason why this is kind of a random slide, but it encompasses everything that I'm talking about, it goes back to using everyone on your whole team and having everyone on the same page, and really spending a good amount of time in your IDGs, not just talking about, oh, went to see patient so-and-so, they were doing good. No, like what meds are they on? Is it working? What else can you do? Before you add another opioid, send in your chaplain, send in your social worker, talk to your pharmacist. What can we deprescribe? Can we take off? What medications can we take off so we don't get in this cyclic cycle of we have another symptom that actually came from another med, but instead of removing that med, we're going to order another pill, and we go on and on and on. So Cicely Saunders, I just want to meet her. So her background is she was a social worker, then the war happened, then she became a nurse, and then she became a chaplain. And while she was a chaplain, she really got into hospice and terminal illness, and she really focused on pain and symptom management for the terminally ill, and realized that that was not an area that was being studied or researched, and not a lot of people were into it. So as a nurse, she tried speaking to the medical community, and they were like, yeah, we're not going to listen to you unless you're a doctor. So she did that too. Went to medical school, and then she started St. Christopher's Hospice as the first research and teaching hospice to specialize in pain and symptom management. So every time I'm looking at utilization, or I go through reports to see the top meds that the hospice is using, that's something that I always look at first. If you have a patient on multiple opioids, multiple anxiolytics, melatonin, all of those things, are you thinking about everything that is contributing that? So what Dr. Saunders kind of came up with was social pain, psychological pain, physical pain, spiritual pain, that can all manifest as a physical pain. So if you have a patient and they have generalized pain and they're not really able to tell you what makes it better, what makes it worse, or where it hurts, something else might be going on. So that's when you ask about the family. You ask about what their mood is, which we should always be checking that on every time you visit the patient. We also forget about that. How's your mood today? And spiritual pain. Where are they in their spiritual journey as they know they're facing death? So all of those things can manifest as a physical pain, or as a nausea, or as an anxiety. So that's my random thing of the day. And I still don't understand why we don't use our social workers and chaplains as much as we should be. So then the other things that vendors will come, they'll save you money. We can lower your cost. So there are traps involved with this. Some of the things you want to make sure you're comparing apples to apples, not apples to oranges. There's so many different models for how vendors operate and how you can utilize them and the things that they offer. So make sure you're comparing apples to apples when you're vetting vendors. Per diem. So per diem from a PBM standpoint can be kind of tricky. If you don't really understand formularies and per diems, that can get real expensive real quick, because if you don't have a formulary, you always want to know your formulary first. So if you're going to be offered, a certain per diem rate, but if you stray from your formulary, if it's a very strict formulary, you stray from the formulary, then you're going to pay premium prices on those. So always make sure you know what the formulary is and what you're getting with that. What are the extras? Not just the extras that they're going to give you, but what are the extras they're going to charge you for that they're not telling you right up front? So from the PBM side, because I'm going to pull them in later for the med supplies and the DME, but in the PBM world, so are you paying extra for medication reviews? Are you paying extra for a certain amount of PAs or things like that? You always need to know how many extras are going to be tagged on, and compare apples to apples from what you have now. Quality versus quantity. Compliance. So what are they going to offer that's going to help you with your compliance? And then reporting, which was what this whole thing was supposed to be about, and then it snowballed from there. But what reports do your vendors offer you, and are you looking at them? Are they easy to understand? If they're not easy to understand, you need to call them. Hey, explain this report to me. Or if you're not getting a report that's helpful for you, call them. And that's where it goes back to, they should be your partner. They should be someone that you can easily pick up the phone or email them, and they can help you figure out what's going to help you. What is the problem you're having at that time? What's the headache? Where are you wanting to save a cost, or where can you improve your compliance? You should be able to call your vendors and get any reports you need like that, and they should be able to walk you through those. So the other thing, so they can increase your efficiencies, but you have to know what your deficiencies are before someone can come along and sell you on making you more efficient. So it kind of goes back to that first graph. So assess the organization's efficiency. So are you giving excellent patient care? Are you providing education for all of your staff to keep everyone on the same page? Do you have quality supplies? Or are you, my husband always gets on to me because I used to buy like a purse at Target every few months. I'm sure I'm not the only one in the room who does that. And then the purses would break because I have kids and they're gross. And so I would just keep buying purses. And he was like, why don't you just buy like a really good purse every now and then it'll last you. Well, I don't want to spend that money. Well, if you spend that money now, then you don't have to keep nickel and diming it. So it's like that in this world too. Make sure that what you're getting is quality, especially when you're talking about med supplies. Ample equipment and services. Are you getting everything you need in a timely manner? And then pharmacy supply and delivery. So what's your cost per patient per day? Are you de-prescribing the way that you should? A lot of times when I talk to administrators about their utilization, they're not really surprised. They're like, I know, we could cut back on Eliquis, or we could cut back on this or that. Not cut back on it. That's the wrong way. I'm not a fan of Eliquis in hospice. Just get that out there. But the administrators aren't often surprised because they're the ones looking at the reports. They're the ones who see where there's some incongruency with their reports and their money. Then when I talk to physicians and providers and all of a sudden they're seeing pricing with the meds that they're ordering that should have been de-prescribed, they're like, oh, and they're very surprised. So again, if not everyone's on the same page, no matter what you're teaching your nurses, if your providers aren't pulled into that, it's not going to make any difference. So then just the top 10 standard survey deficiencies. So number one, plan of care. We already talked about this, but one of the most helpful things that I ever heard at Sono was a few years ago. Gary and Amy, what was Amy's last name? Smith. She had a plan. So are the facilities following the hospice plan of care? I don't know about you guys, but not really all the time, very often at all. So she had a really good system where she would go into every facility that they contracted with, and they had a binder, and it was sticker form, and she whipped those nurses into shape. They absolutely followed their plan of care, and she had it down to, they even knew exactly, the nurses at the facility knew exactly who to call. They were never to call any of the vendors for anything. They couldn't call in prescriptions. They had to call that one nurse. So she had it down. So that is something that I do see a lot of facility nurses or facility providers calling in medications, and somehow that has to be stopped. So if anyone has the secret sauce on that, please share with the group. Drug profile, are you getting your medication reviews on admission and with any change? The content of care, so make sure that the plan of care reflects the patient and family goals. It's not just the patient, it's about the caregivers too. Must include all services necessary for the palliation and management of the terminally ill and related conditions. The level of activity, so your volunteers and your volunteer hours need to equate to 5% of the total patient care hours of all of your paid staff. Coordination of services, ensure that the care and services match and align with the plan of care. And then standard prevention, COVID, I feel like I should have a trigger warning on this one. Supervision of hospice aides. So the RN to complete the on-site visit at least every 14 days to assess the quality of care. And this visit ensures that all services ordered by IDG are meeting the patient's needs. Again, if you're not talking in depth about your patients at your IDG meetings, you're not really progressing anywhere with that. Then your bereavement plans and the content of the plan of care, so more detailed scope and frequency of services. And then 10, the clinical record. This is all duh. You guys know these things. But it's more talking about those because how can your vendors help you more? You have these relationships with their vendors. What can they be helping you guys with when it comes to those top 10 deficiencies? And then I feel like that's the face after survey. which is a fun time. And then are you meeting all the requirements? So if you miss any of these steps, then you can get 4% doc on your reimbursement. So make sure that you're dotting all your I's and crossing all your T's. So then, man, I'm talking really fast. I'm sorry. Okay, so when it goes to reports, so a few of the reports that I really like that PDC offers, obviously, are the PPD report. Now, with all of your vendors, you're not going to get a really good PPD report if we don't have the accurate patient days for that month. So if you're not ordering directly through your vendor and you're not staying on top of telling them admission dates and discharge dates, you're not going to get an accurate number unless you send your vendor your patient days every month. That's something we're really trying to push right now. Hopefully we'll get better, but that is something to keep a very close eye on. And that should be a conversation with your vendors of where is your PPD at? What should it be at? And then let's take a deeper dive and see what we can help with. This is one that I really like. So these are the top 50 medications each month that have been ordered. This is a really good clinical and financial way to look in 2 seconds and see where the bulk of your money is going. So the color coding at the top, non-formulary medications, which if you're on a per diem model and you're looking at the non-formulary medications, those are going to be premium prices if you're on a per diem model. So watch out for that. And then the tier 3 in blue, the tier 3 medications, those should be your third line, your tertiary medications. You shouldn't start off on ordering those medications. And that's another big thing that the providers need to have a solid understanding of. How does your hospice view tertiary medications, those third line therapies? Are you guys okay with it? Do you have limitations? Do you have a protocol in place? Hey, before you start a fentanyl patch on this patient, we need to follow these protocols. Because a lot of times if you got your patients from the hospital, and I know this from working on the inpatient side of that, those physicians, the hospitalists that work in the hospital, they're going to start them on whatever's worked for another patient in the past. And they're not thinking about the cost. They're not thinking about discharging that patient onto palliative care, onto hospice. So a lot of the really expensive ones tend to be oxycodone or your combined medications, Percocet. So make sure that everyone is on the same page. If you get a patient, let's say on Percocet, does your staff know, okay, can you tell me when you were prescribed Percocet? Has it worked for you in the past? Have you ever tried morphine? Do you have allergies? Morphine is still gold standard. It's still very cheap. So there needs to be some sort of protocol. If your staff, your nurses, your providers are going to order those third line therapy medications, what is the protocol to have that approved? And are you all on the same page knowing what your prescribing habits should be? The big one, the one that shows up on almost every utilization report, which ironically is not on this one, of course. It's rigged, is Eliquis. Eliquis is so expensive and it adds up. But what happens is, and I have a whole nother presentation about this, usually those patients who are on Eliquis and Xarelto, they were seeing a cardiologist, they probably had an acute event or they have AFib. But then as the patient digresses, they stop seeing their cardiologist or their specialists. So then we just keep them on it because that's a scary conversation to have, right? Telling the patients and the caregivers, we're going to take you off Eliquis, because then they automatically think they're going to wake up with a stroke tomorrow. But we have to be educated on having that conversation. Risk versus benefit on some of these expensive meds. It's very difficult to outweigh the risk of a head bleed, especially if you have a fall risk patient. If that patient would be in a facility or in a hospital, would they qualify as a fall risk and get that lovely yellow bracelet? Then they probably don't belong on Eliquis as they digress at home, as they have medical equipment in their house. They've got a bedside table now. They've got a commode. They've got bed rails, and we're keeping them on Eliquis even though they're not even really eating anymore, but we're keeping them on it because that's a hard conversation to have. So then he falls, he hits his head, he has a head bleed, you take him to the ER, you pay for his admission on a vent, and he dies on a vent with no family and COVID. So risk versus benefit on all of your medications, especially those dangerous ones, and it's not about the money, it's about the patient care. I think I've said enough there. Got on my soapbox. So then this is another one that shows you by category where your more expensive patients lie. Heart almost always shows up at the beginning. Again, that's usually for the Eliquis, which we need to be asking, just like you do a pain assessment. Where's your pain? When is it better? When is it worse? You need to be asking on some of those specially prescribed meds. When were you first prescribed Eliquis? Why were you prescribed Eliquis? Have you ever followed up with a cardiologist again? All of these questions we really need to ask. But anyway, it's usually heart as one of the more expensive. COPD comes up there, which that's another thing. You could save bukus of money if your providers will time their face-to-face, or the nurses will time their face-to-face when watching the patient use their inhaler. Because end-stage COPD patients very rarely have the lung capacity to hold their breath for 10 seconds and take in all of that medication, and there goes $30 that didn't even make it to the lungs, and they couldn't even use it appropriately. So really try and get a good feel for those inhalers, and are they actually being used appropriately? Are they still working? And would a nebulizer, would an albuterol probably work better for that patient? And again, it's not about the money, but I'd much rather have a nebulizer that I know was helping me every 4 hours rather than my inhaler 3 times a day that nobody said, hey, that's probably not working for you anymore. And the other thing is dementia, which usually falls toward the front of that too, heart, COPD, and dementia. Whereas, again, a whole nother PowerPoint on that thing for another day, but Alzheimer's meds can add up really, really quickly. And they're not meant to be on for years, especially at the end of life. That is a really difficult conversation to have. So one of the best key indicators to start out that conversation is, can you tell me about if the patient's still responsive, or can you tell me about your dad? What do the last 6 months look like? Has he gotten worse in the last 6 months? Have you seen a digression? Yes? Okay, right there. Mamantin's not working for you anymore. It's time to move off from that. But those are conversations that we don't do a good job at being comfortable and confident in having those, and backing ourselves up with data and with literature and being confident with that. So we tend to just let it go because it's awkward, which then adds up. It puts our patients on 17, 20 pills a day that aren't working anymore, but we didn't want to talk about it, so we kept them on it. You got to get awkward sometimes because that's what's best for the patient. The patient's gut's going to be the first thing to die. We're still pushing pills down them, and I swear if I'm dying and someone crushes 4 pills and puts it in crappy applesauce, I'm gonna be ticked. So don't do that. Sugar-free pudding, it's the worst. Okay, so that's about all I have. So I'm phoning a couple friends on this because I didn't want to just talk about the pharmacy side of it. So I'm gonna have Billy talk about the med supply side and some reports there, and then we're gonna pull in Jared from the DME standpoint.
And you're coming back up, right? Oh, okay. All right. I didn't really prepare anything specifically, but if we can put the PowerPoint back up. Really, when it comes to hospice, the big thing is, what's my cost per patient per day, right? Everybody's always wanting to know what my cost is per patient per day. I go on sales calls. I'll meet with people and say, my first question is, what's your cost per patient per day for med supplies? And I would tell you probably about 95% have no clue. And that's okay, but you should be working with a vendor that can provide that. All it is a simple question. Just reach out to your vendor and say, what's my cost per patient per day? Give them your actual patient days for the month, and maybe typically look at a quarterly period. I try to do, when customers request them, I give them quarterly business reviews, January, February, March. Give me your patient days for January, February, March. I can take a look at it and analyze it, as I did with this customer here. This is an actual report for a local customer here in Phoenix. One thing to take note is every market is different for med supplies, and I would say it's probably the same for DME as well. The average cost per patient per day in the Phoenix market is upwards of $5 for med supplies. And the reason for that is, number one, the competition. Number two, there's group homes here. in the Phoenix market. If you don't know what a group home is, it's literally could be your neighbor, and they have hospice patients in their home. All right, it's licensed, but there's a lot of those here in the Phoenix market. And what they do is they say, hey, we'll let you have this patient. We'll give you the referral, but we need 3 packs of wipes. We need 2 packs of underpads. We need 4 boxes of gloves. And you're basically supplying the whole place. Everybody knows it. It is what it is. But that's one of the reasons why costs in Phoenix are much higher. You go to a market like Denver, and the average cost in Denver is closer to the $2 range. Because they don't have group homes and they're not providing protective underwear. So anyway, I can go on for days on this stuff, but it's important to know what your cost is per patient per day. That's a starting point. So for instance, like this customer, we know what the cost is per patient per day. Now this customer drop ships to patients' homes, so their cost is going to be higher, right? They're paying shipping costs, etc. After you do that, it's good to take a look at it on a category basis. Wound care, skin care, nutritionals, incontinence, gloves, OTCs, things like that. I think we have about 15 different categories up here. It's good to see what the cost is per patient per day by category. I've been doing this for 19 years. I know where you should be, even if you're in Atlanta or you're in Phoenix or you're in Denver or Vegas, wherever you are. I know where you should be in your cost per patient per day. It's also good to communicate what your budget is, right? If I have a customer she tells me exactly, she goes, Billy, my budget is $2.10. I'm like, okay, let's get there. How can we do it? Right? We should work together. It needs to be a partnership where you can trust in your vendor and have that communication where we know where you need to be. And we can work together on that. Knowing what your cost is per patient per day on categories is most important, because you can be high on costs, but if you don't know why, it's not doing you any good. For instance, this customer is might be really high on wound care, right? If they're really high on wound care, why is that? Sit down with them and say, hey, these are the areas. Then we can dive down and look at that category, right? And we can look at it by not just cost per patient per day, but usage per patient per day. You shouldn't be using more than 7 to 8 gloves per patient per day. You shouldn't be using more than about 2 to 3 incontinence. When I say incontinence, that means underpads, protective underwear, and briefs. Shouldn't be using more than about 3 each of those per day per patient. Okay. If you're over that, that's something's wrong. Maybe you need to take a step up in quality, or maybe you're providing too much to your patients. Wound care, your cost per patient per day should be under 40 cents. And that's even kind of on the high side. Typically you want to be between about 15 and 35 cents per patient per day. So knowing where you should be is important. If you go to the next slide, please. And this next slide just shows it's different for every patient, right? This person's cost is much lower, right? They're right around $1 per patient per day. So knowing where you need to be is important. Knowing where you are is important, and then communicating to your vendor partner. It is a partnership, and it should be treated as a partnership. Share with them what your costs are per patient per day, what your census is, where you are, and then where you need to be, right? If I have a customer comes to me and says, Billy, you know what? Right now we're running at $3.25. We really need to be at $3. I'll say, okay, let's get there. How are we going to do this? We'll sit down, we'll make adjustments, we'll look at things, I'll have suggestions, but that's really what needs to be communicated. So work together with your partner and understand your reporting. Ask for those reports because they will help you. And you should know where you are and where you need to be. All right, Jared?
Thanks, Billy. Yeah, thank you. All right, I'm Jared with Qualys, and I've been tasked to talk with you about DME. So right now, everyone in this room, you're either working with a DME benefit management company like Qualys, you're working with a local DME provider, or you own your own DME. So you guys can head out if you want. This doesn't apply to you if you're on your own DME, right? You can cut out early, go take a nap or something. So, and there's not a right answer. I'm not going to sell you on DME management because it doesn't work for everybody. I'm sorry, I'm a horrible sales rep, I guess, but it may not make sense for your organization. But at some point, either a direct DME supplier will try to sell you, or someone like Hall, myself, will show up, knock on your door, and try to bring you Chick-fil-A in and talk with you. So the first thing, Jaymie, that you hit on that I think is incredibly important is you have to understand where you're at at today to know where you're going, right? If you're selling a boat, if you're flying a plane or whatever, you set a compass heading. And if you deviate, it's easy to see. You get off track. But if you go into a sales meeting and someone is trying to sell you on something and you do not know where you want to go, you easily can get kind of swayed to their product or something that you don't need, and you're making an impulse decision. So know where you're going and stick to it. The second is, do they understand your goals? Do they understand your priorities? Do they understand your headaches? If not, they're making up what they're selling, okay? They've got to understand your goals, your priorities to be your partner. Are they selling vaporware? It is very hard for a salesperson to say no. So when you ask them, hey, does your software do this? Do you have 24/7 support? And do you provide Airvo machines or Trilogy ventilators? It's usually a gut reaction. Yes, we do that. And then they have to figure it out later. We were talking to a hospice recently, and an EMR sold them on this, this, and this, and they got none of those things. So ask for referrals, ask for references, ask for hypotheticals. All right, you say you do this, how do you do it? One of my favorite things we do in our meetings is we shut up. And our potential hospice partners ask a lot of questions, a lot of hypothetical questions, and then we get to be truthful with them. Not every sales rep is delightful and as truthful as Hawthorpe over here. So they're going to try to sell vaporware that doesn't exist. It's hard for salespeople to say no. Again, that's not just DME, that's just life in general. All right, are they manufacturing value? If you have someone sitting in front of you and they're grasping at straws, if they don't understand your goals, your priorities, are they manufacturing value? Are what they selling you, does it save you money? Does it save you time? Does it save you a headache? If they're grasping at straws, they're probably not going to be a good fit for you. Are they an open book on their pricing models? I know everyone may be closed book to a certain degree, but do you understand how they're incentivized? Do you understand how they're making money? We took over a hospice partner recently that their vendor made a boo-boo. They copied the CEO on an email that says, hey, we need this very expensive piece of DME. It doesn't matter what you charge us. We mark it up to the hospice anyway. And then they immediately called us and said, hey, you spoke to us about 6 months ago. What do you do again? How do you do your pricing model? So how are they incentivized? Are they incentivized to help you control cost? Or are they incentivized to you spend money, we're going to add on top of it? Do they provide data? Hall says this a lot, and I completely agree. It's your data. You own it. You need it. Okay. Are they giving you the data you need to make a decision? Are they hiding it? Are they withholding that information? Are they providing the data in a simple format? Are they providing the data in a relevant format? Is the data that they're providing in line with your priorities? Cost savings, for example. Let's start with this one. If your DME vendor or if someone's selling you, what your priority may be, on-time deliveries. That's very important for hospice, right? Especially hospital discharges. So are you getting the data you need to help with that? So what some hospices do, if your DME vendors are habitually late and getting you DME, they start ordering every order a stat. I know you can't see that, I'm sorry. But that's the stat percentage little icon. So if a DME vendor is late, they're going to start placing every order a stat. Well, it's actually counterintuitive because every time you place a stat order, your DME vendors are rerouting for the day. So are they providing the data? Are you getting these metrics to make those decisions? Do you have that open book relationship with your DME vendor to where you can have these business reviews and sit down and talk to them about these things? The data also comes in handy with, after you move forward with your vendor relationships. One of them may be cost drivers. How'd I go forward, Jaymie? Oh, perfect. Thank you. So how are they incentivized? These DME providers, let's say you have something outside of your formulary and it's a Broda chair. Do you use Broda chairs? Anyone in this room? You raise your hand if you don't mind. Okay, so about half. Ohio, Midwest, we see a lot of Broda chairs. Alabama, Broda chairs do not exist yet. Okay, it's really regional. It's true. Low air loss mattresses. It's just understanding the equipment that you're getting. The lowest hanging fruit for most hospices are APPs and gel overlays. A lot of your vendors today are probably providing a high density foam mattress with every bed that you receive, a Medicare coded Group 1 support surface with every single bed. And then if you're ordering an APP or a gel overlay, you may be paying an extra $1 for that overlay that is sitting on top of that high density foam mattress. So you have a Group 1 mattress and a Group 1 overlay on top of that mattress. And this is where the partnership comes in. Some vendors will raise their hand and say, hey, that's not needed. Others may not raise their hand and say, that's another $1.50 per patient per day I'm getting for that gel overlay or that APP, or understanding when to upgrade to a low air loss mattress based on wound prevention versus wound treatment. Just having these conversations with your vendors and a truthful, transparent conversation can save you a lot of money as well. Just realizing you're not providing the right equipment at the right time, therefore you're over prescribing, you're overutilizing, and this is what we try to do at Qualis. We, like Jaymie, we push a lot of reports, but if it's not helpful, if we don't understand your priorities, then we're failing. DME is my world. It's my life. If DME is your world and your life, then I'm not doing my job well. If you're one of our partners, then come see me. But we can very quick to send Excel spreadsheets, dashboards, but having something in a simple format, KISS, I don't know if you meant it or not, but it was all caps, keep it simple, stupid, right? Was that part of yours? That's what she meant on her first slide. Keep it simple, stupid. So just having the data in a format and a partner to transcribe that data for you. It's your data. You own it. If you're not getting it from your vendor, ask them. But I guess, Jaymie, my takeaways on DME from what I've seen, understand where you're at, understand where you're going, including your priorities. Are people selling you vaporware that you don't need? Are people are they trying too hard and you can't really see how this company fits into your goals? Then it's probably not a great fit. And then after that, just make sure that they're giving you the data that you need and that they're helpful in their decision making.
Thank you. I'm super thankful that both of these guys stepped up and helped me with that, because I don't want to just talk about the pharmacy side, but also that's the really cool thing about Sono is that's weird. I'm on the screen. Oh, that was your slide talking about the difference.
So if you're a large hospice, data can also help with your internal decision making. So we spoke about BrotaChairs earlier, right? This is a hospice partner in a lot of different states and cities. You can see Brota, Oxygen, low air loss mattress, and then Group 1, which is APP and gel overlays. Some locations have high BrotaChair utilizations, others have zero. So again, there's not a right and a wrong answer. It's just internally, are we sourcing the data internally to make decisions if you're a larger organization, and some of you are. So make sure you're capitalizing on your internal resources as well. And sorry, I put a mint in my mouth because I thought I was done talking. So that's that clacking, all right?
Okay, sorry, I forgot about that slide.
I forgot I included it.
Oh, there you go. All right, so yeah, thanks to these guys. My favorite thing about Sono is we're not going to sell you guys here, so they're the experts. If you have questions or you'd like to know where you are or how to have these conversations, we're all going to be around for the next 3 days. So pick their brains, pick my brain, pick anyone's brain, even if you're not our partner. We'd love to answer your questions. So thanks, guys.